So thank you very much for joining us today. We're running just a couple of minutes behind, but we will be starting shortly. So I can now officially welcome you to our digital Infoday session. Thank you for joining us. This webinar will explain reasons why myeloma may relapse, how the relapse will be recognised and the treatments available. It will also explain why myeloma can become refractory to treatment and what options may be available for these patients. This webinar will be recorded and available to watch on our website afterwards. And if you'd like to chat to each other, you can use the chat box function. And if you have questions for the speaker, please use the Q&A box, which can be found at the bottom of your screens. So my name is Alice, and I am the Patient Information Manager at Myeloma UK. My team and I produce information that covers all aspects of myeloma and its related conditions, from treatments and tests to how to live well. This information is available in a variety of formats, such as online booklets, videos, and printed publications. And we ensure that our information is accurate, relevant, and accessible so that you have information you can trust. Some of you may not be that familiar with Myeloma UK, so I'd like to tell you briefly who we are and what we do. Myeloma UK exists to support all those affected by myeloma and its related conditions, which include smouldering myeloma, MGUS, and AL amyloidosis. We are patient-focused and we aim to empower, inform, and support patients in everything that we do. As an organisation, we rely on the generosity and kindness of supporters fundraising and donating to us. We receive no government funding, so your support is vital, and we are truly thankful for all contributions as they allow us to continue working to help patients, their family and friends. Now I'd like to welcome this evening's expert, Dr. Neil Rabin. Dr. Rabin is a consultant haematologist at University College London Hospitals and North Middlesex University Hospital. Thank you for speaking to us this evening, Dr. Rabin, and I'll now hand over to you to start our presentation.
So thank you very much for asking me to talk. Myeloma UK is a fantastic organisation, so it's a real privilege to be asked to talk at this event. So this talk is going to talk about what is relapsed and refractory myeloma. The second thing will be when to restart treatment and what factors we as clinicians, and I guess what we would talk to patients about when we talk about retreatment. And then, importantly, what treatment options there are for relapsed and or refractory myeloma. And that will both be in the setting of what's available within the NHS framework. And then towards the end of the talk, we'll talk about clinical trials and how clinical trials work. So I think it's really important to think about what the take-home messages are. So there are three key take-home messages. The first one to talk about is the fact that myeloma will return at some point, but it is difficult to predict exactly when this will happen, but we'll talk about the factors related to that. The second thing will be the test and symptoms or complications that help us to identify whether a patient is relapsing. And then the third thing to talk about, the take-home message, is what treatment options are available for relapsed and or refractory myeloma. So I think it's probably important to just define what we're talking about. So you can see here patients who have this early stage asymptomatic myeloma. They have symptomatic disease that require treatment. Often patients are unaware that they have myeloma at that point, so they may have either gone through primary, secondary care. They have induction chemotherapy, their disease is under control, and then they have what's called a period of remission. And I think if you look here, remission means that the myeloma cells and the paraprotein are either no longer detectable or they're detectable, but they're at a very low level. And importantly, there are no clinical symptoms of myeloma. The second thing that we talk about is what we call plateau or stable disease. And that just means that there is a small amount of myeloma protein, but actually that protein level, or what we call paraprotein, or for some patients it's just the light chain, so it could be the kappa or lambda light chain, is at a stable and unchanged level, and that's what we as clinicians would call a plateau or stable phase of a patient's condition. And then we're talking about patients who have been in either remission or in a stable plateau phase, and then obviously over time, and it's difficult to be precise as to what that time period will be. We will talk about the factors that might give us more of an indication, is a period of relapse. So the relapse is the point at which the myeloma returns or becomes more active, and that will be after a period of either remission or stable plateau phase. And then there's a stage, usually towards the latter part of a patient's illness, where the myeloma no longer responds to treatment, and we would refer to that as refractory myeloma. So relapse is really when the myeloma has come back, and refractoriness is the fact that, in addition to the fact that the myeloma has come back, it means that the treatments aren't going to necessarily change the amount of myeloma or complications related to myeloma at that point, although clearly there are many things that can be done at all stages. So if you look here, that this diagram talks about the course of myeloma, and it talks about what's called this relapsing and remitting illness. So you can see here that patients may have this early stage MGUS or smoldering myeloma. They then are diagnosed with symptomatic disease requiring treatment. They respond to treatment, and then they go into either remission or this stable plateau phase. They have a period of relapse. They would respond, and highly likely respond to treatment at that point. They then would go into what's listed there as a second remission or another period of plateau phase. And then again, the myeloma returns, relapse, and then it remits, and then it relapses again. And the period of time between each of these phases is variable. So for some people, it may happen in relatively quick succession, but you'd imagine that certainly for most people, there would be a reasonable period of remission, usually after the first induction therapy. I think the other thing that's probably important to talk about is the fact that often patients are having treatment for a defined period of time, usually in the earlier phase of their illness, whereas often in the relapsed and/or refractory setting, patients may be having treatment given on what's called a continuous basis. And again, we can discuss that later. So in terms of detecting relapse, or whether somebody has relapsed and/or refractory illness, we as clinicians undertake clinic reviews. So patients will be coming to clinic on a regular basis. I think the important issue is that often when patients are diagnosed, it's an unknown problem. Often patients may present with fatigue or back pain, may have problems with their kidneys or other things, and people are unaware what that is due to. And then obviously the diagnosis of myeloma is made, and often say patients have a paraprotein or a light chain. In the relapse setting, or when we're monitoring for relapse, patients have a known condition, and so we have biomarkers or ways of monitoring patients to detect myeloma, and that means that we're able to understand patients' condition and whether things are going to change and whether patients are going to need any treatment. So the regular tests that we would do in clinic would be blood tests. So we would check paraprotein, free light chains. Imaging is clearly very important, so that might involve either CT scans or MRI or PET scans. Blood tests are clearly important to check whether people are developing any problems with anemia, any problems with their calcium, any problems with their kidney function, and then I guess general organ function. So people may have tests of their heart or more formal tests of their kidney. I think the important issue is that blood tests have to be taken in combination, or any test have to be taken in combination with how the patient is. So often we're detecting things in patients who are well, but actually we're using it as a way of understanding at what point would we want to intervene. The other thing is that there aren't absolute values, because often patients say, well, if my paraprotein goes to a certain value, is that the number at which you need to intervene? And I think from a clinical point of view, it's the trend is the most important. So for example, a paraprotein of changing between say 3 and 10, if that was over the course of 6 months or a year, is clearly a relatively slow rise. Whereas, say, a paraprotein that was changing from 3 to 10 over the space of 6 or 8 weeks is more of a dramatic change, and that may mean that we may want to intervene sooner than later. And finally, I think it's really important that we're trying to put all of this information together so that we can give good and appropriate clinical advice. So it's all important, the history, how the patient is, whether it's either done in a remote clinic or a face-to-face clinic, and then to put that in mind with the paraprotein, imaging, and any other tests. So it's not one thing that's going to give you the answer, and everybody's different. So the other thing that's important to talk about is we talk about relapse, but we talk about 2 different types of relapse. So there's something which is called biochemical relapse. So biochemical relapse would mean that somebody who has a paraprotein or a light chain, when they were diagnosed, their paraprotein was of a level and it had gone down to it had either disappeared or it was a very low level. And for that person, their paraprotein or light chain has gone up. And there are certain criteria that we use to determine the level at which somebody has biochemical relapse. And often patients are well at that point. And those are patients often that can be monitored in clinic. We don't necessarily need to intervene, but we're aware that things are changing. And I think the rate of change, what problems people had had in the past, I think is really relevant. And it doesn't necessarily mean that we need to rush at all. And then the second type of relapse is what we call clinical relapse. And clinical relapse is where people have symptoms or signs that are related directly to the myeloma. So that might be that somebody has developed new problems related to back or bone pain. Maybe they have developed fatigue secondary to anemia, problems related to kidney function or other things. So they've developed something that is directly attributable to myeloma causing a problem, and that's what we call clinical relapse. And if somebody has clinical relapse, clearly they're going to have treatment. Some patients with biochemical relapse will also have treatment, but it's not inevitable that if you have biochemical relapse that you will instantly start treatment. And that's a discussion that your clinician will have with you. So I think one of the things that people always ask is, can relapse be predicted or can it be prevented? And I think in terms of prediction is a difficult thing because the timing of the relapse can't always be predicted. But there are certain things that kind of would give us an idea as to whether somebody is likely to relapse. So we know that if somebody has responded well or to treatment compared to somebody who maybe had their paraprotein hadn't gone down as much, we know that probably that person's myeloma is likely to come back sooner than others. There are issues possibly related to people's age, frailty or comorbidity that again would give us an idea as to whether somebody is likely to relapse sooner than somebody else. And we know very clearly now that there are genetic changes within the myeloma cell, which we can detect. It's often done at diagnosis, and it's called FISH, or fluorescent in situ hybridization. It's a certain technique which is done on the bone marrow cells, often when people are diagnosed. So it's one of the reasons that we do a bone marrow aspirate. There are genetic changes, and again, that would give a clearer idea as to whether patients are likely to relapse sooner or not. I think what's really important is that people are clearly an individual, and all of these predictive factors are based on populations of patients. So the person with myeloma is one individual with myeloma, whereas these factors are based upon what we know if we had 100 or 1,000 patients and we were comparing groups of people. So it's not inevitable, for example, that somebody who had genetic changes related to myeloma that might suggest that they're going to relapse earlier, it's not inevitable that they will relapse earlier. It just means that if you were to look at a population of patients, they would, based on a population level, relapse more likely or quicker, say. The second issue is in terms of prevention. Sorry, if you could just go back. The second issue is prevention. So we can't, unfortunately, prevent relapse or delay relapse. That's just an unfortunate fact. I think it's important to follow a sensible diet and lifestyle, and obviously to keep as fit and healthy as possible. Thank you. So, right, so in terms of the aims of treatment, so I think in terms of the aims of treatment, it's really important that it's a partnership between the doctor and the patient. And as I've said, it's really what's right for the individual, and everybody might have slightly different circumstances. I think the aim of treatment is to control the myeloma again, and importantly, maintain quality of life. So quality of life is really critical. And the thing that we're weighing up in clinic is a combination of, we're weighing up these two things. One is what side effects, and unfortunately all treatments have some side effects. You can't say it has no side effects. So what side effects are there with the treatment? And then the second thing is to control the disease and to reduce symptoms. And so clearly if somebody has clinical relapse, we know that somebody has a problem related to their myeloma, so we need to intervene. And so on the balance of the risk of controlling the disease versus side effects, it would clearly go in favour of treating. But I think for somebody who has biochemical relapse, often very, very well, no issues at all, you've only ever known about it because the doctor has said, by the way, on your blood test, your paraprotein has gone up. And that understandably causes concern and alarm. So I completely get that. But actually, if we know that, for example, the paraprotein is going up very slowly and you're being monitored and you're having imaging and regular review, I think it's completely safe. And actually, I would suggest is the right thing to do for patients would be to monitor and then to not miss the window of opportunity to treat, because you do want to prevent clinical relapse, but actually a period of observation is completely appropriate. Okay, so I think that kind of emphasizes the point that I've made, that not all patients with relapse will need immediate treatment. So it undoubtedly causes anxiety. Often the discussions that I'm having with patients when they have evidence of biochemical relapse will go over several months, if not longer. I've had patients who I've observed for well over a year, far more than that, with biochemical 2 years, with biochemical relapse that have not needed treatment. It's just that they need a discussion about, is there any evidence of clinical relapse? Were there problems at diagnosis that we're particularly keen to prevent? So, for example, if somebody had kidney problems at diagnosis, it would be important probably to intervene earlier to prevent kidney problems. Or, for example, if somebody had significant bone problems, you'd want to intervene early to prevent the development of bone problems. If somebody, for example, had anemia as their predominant issue without any other particular concerning things, you might be quite happy to have a period of observation. Essentially, you're taking stock of the situation. So I think it's completely appropriate to watch and wait if you have no symptoms such as pain, and it's pain that we're attributing to myeloma, because we all have kind of aches and pains now. So it's important to describe to the doctor what pains you have. As I've said, no evidence of organ damage, because if there was evidence of organ damage, that would be clinical relapse. No evidence of any anemia, and usually patients would have a slow rise in their paraprotein or light chain. So in terms of the treatment options, I think this very nicely describes the approaches that we think about. So the three approaches are, firstly, should we repeat the treatment that somebody has had previously? So somebody may have responded, for example, very well to, for example, a Velcade-based regimen when they were diagnosed, may have had a stem cell transplant. It may have been several years and then their myeloma comes back. They haven't had, for example, significant problems with neuropathy, and actually it would be completely appropriate to think about retreating that patient with the same treatment that they've had before. I guess a lot of the issues relate to what is available for treatment, if we're frank and honest. The second thing is, I think, is if somebody's on a treatment already, do we add anything to that to augment, to get the response even better? So maybe the classic example would be somebody who's on lenalidomide maintenance, for example, or they're on lenalidomide at, let's say, second or probably third relapse. They're on, for example, there could be ixazomib, lenalidomide, dex, or maybe just lenalidomide. Their steroids were stopped because they had no detectable paraprotein and they were very well. Maybe the addition of steroids or another drug to the existing drug, we know again can get disease control again. So that would be the addition of a treatment to what the patient is receiving already. And then the third thing would be to try something new, to actually try a different way of killing the myeloma cells. So that might be a new type of chemotherapy. So for example, if somebody's not received lenalidomide before, maybe you might start them on a course of lenalidomide. Or for example, you might add in the example of the patient who'd had Velcade at diagnosis and a transplant and had a period of remission and relapse, it might be the addition of daratumumab, for example, to the Velcade treatment, which I discussed. So it's either repeating what somebody's received before, it might be the addition of a new drug, it might be the addition of something to augment the response of the treatment that they're having already, or to try something new. So in terms of the treatment options, and these are kind of the options, and we talk about first relapse, second line. So second line implies that the first line of treatment is what somebody would have had at induction treatment. They may have then had a stem cell transplant. That's all considered within one line of treatment. And then their myeloma has come back, and that's what we term first relapse or second line of treatment. And these are the treatments that are available through NHS England and through the Cancer Drug Fund. Probably the commonest treatments, I would say, would be daratumumab with bortezomib and dexamethasone, which is the third one down. It's, I think, unlikely you're going to have bortezomib on its own. If somebody's not received bortezomib in the past, patients may receive carfilzomib with dexamethasone. Carfilzomib is another proteasome inhibitor, which is a more potent drug to bortezomib, and that's given intravenously. So patients would need to attend hospital on a regular basis. Then there are the oral proteasome inhibitors, such as lenalidomide and dexamethasone, potentially thalidomide. Unfortunately, steroid is the backbone of all of the treatments that we give, and that would either be dexamethasone or prednisolone. And then there would be a group of patients that would receive a stem cell transplant after induction therapy. And for a very small group of patients, they may have a mini allograft. The other thing to say is that in light of COVID, and because there's an encouragement to have oral-based regimens, there are some treatments now that are available They're certainly going to be available until March or April of next year. And that's a mechanism to allow us to give oral-based regimen to limit exposure to hospital. So, for example, at second line now, some patients could receive ixazomib with lenalidomide and dexamethasone, according to COVID planning. And also, if somebody had received lenalidomide in the upfront setting, potentially they could also receive pomalidomide at second line. And that's because the concept of having an oral-based therapy to prevent people coming into hospital to reduce exposure to COVID. I think it will, the concept of a second transplant is if somebody had so it would be somebody who would be suitable for a stem cell transplant. So it's usually patients under the age of 70 who have previously had a stem cell transplant, would have had a reasonable remission from their first transplant, and that's an open discussion with clinicians, but certainly would have had a reasonable remission from their first transplant. Clearly, it would be acceptable to the patient that they would accept a second transplant, that the doctors think that it would be an appropriate thing, that your organ function's fine. Then following a period of reinduction chemotherapy, because all patients would need a period of reinduction chemotherapy, usually for a minimum of around 3 to 4 months, then we would consider a second transplant. And clearly patients have to have sufficient stem cells, which is either stem cells that would be stored from their previous transplant or before their previous transplant, or there will be some patients that they will attempt reharvest of their stem cells. So then after that, you've got what are called third line or second relapse. And the options would be classically patients receiving either lenalidomide and dexamethasone. Lenalidomide is an oral immune modulatory drug related to thalidomide, and that's given daily for 3 weeks, and then you get 1 week off, and then you repeat the cycle again in combination with dexamethasone as the steroid. The Cancer Drug Fund allows us to add in ixazomib. So ixazomib is an oral proteasome inhibitor, so it works in the same way as bortezomib or Velcade or carfilzomib, which I mentioned before. It's given as a tablet in combination with lenalidomide, and it's given, you have 3 tablets per month in addition to the lenalidomide and dexamethasone. And that's probably the commonest treatment that would be given, I would suggest, at third line. And then there will be some patients, probably not many, but there are some patients that would receive bortezomib in combination with panobinostat and dexamethasone. And then when you're getting to fourth line or third relapse and beyond, the options at that point tend to be, the most common combinations would either be daratumumab. So daratumumab is an oral proteasome. Daratumumab is a monoclonal antibody, anti-CD38 antibody. At that stage, it would be given on its own, so what's called daratumumab monotherapy, given in combination with steroids. It's given every week for 8 weeks, and then it's given fortnightly, and then eventually it's given monthly. That would be the same drug that would be available at second line to be given in combination with bortezomib or Velcade, or what's called DVD. But at this stage, it would just be given as monotherapy. And then patients would receive a drug which is related. The alternative would be either daratumumab or an oral drug which is related to thalidomide or lenalidomide, which is a drug called pomalidomide. It's also known as Imnivid. And again, that's given in exactly the same way. It's given in tablet form. It's given for 3 weeks, then you get a week off. So it's a 4-week cycle, and then the medication is repeated. I think bendamustine was a drug that used to be used, has some similarities to melphalan and cyclophosphamide, and then has some crossover in terms of the biochemical structure. to some of the other chemotherapy drugs that we use, not for myeloma, but actually I think it's very unusually, it's not used very commonly now. So I think we probably have better drugs. So most people at 4th line are probably receiving daratumumab, and at 4th or 5th line, patients are receiving pomalidomide. And as I said, you could receive pomalidomide further up in terms of either at 2nd or 3rd line, assuming that you'd received lenalidomide before, and that would be for COVID reasons, and it's only the change for COVID. So in terms of treatment options for refractory myeloma, generally, in terms of refractory disease, the treatment approaches tend to be very similar to what we would say for relapse myeloma. We might try different combinations. We might try and put the drugs together to see if we can regain disease control. So it might be more potent chemotherapy that means that patients need to come into hospital for what's called infusional treatments. So that will be treatments such as DT-PACE or ESHAP, where patients would need to be in hospital for a minimum of, I would say, a week. And for some of these chemotherapy regimens, we would expect the normal blood counts to go down in, say, the 2nd or 3rd week. Patients would often lose their hair, and those treatments would be given over several months. So the actual infusions would be given over a week, and then people would have to recover, their blood counts would have to recover before they could receive any further treatment. Or we might consider more outpatient-based treatment that may be a combination of the drugs that we've spoken about before. And obviously, clinical trials, which we'll discuss later, it may be that there are some newer drugs which are available, which again may be effective in this stage. But it's fair to say that if you're in the refractory stage of the disease, whatever treatments you try may not work.
Well, thank you so much, Dr. Rayburn. So we've come to the first of our Q&A sessions, and thank you to everyone who submitted questions beforehand. So the first question this evening is from Ian, and he is asking, at what point do patients stop being offered treatment, and how much control does the patient have to stop the treatment themselves?
Okay, so I think the decision for whether somebody has treatment or not is the patient, and is only the patient's decision. The doctors won't make that decision. I think the bigger issue is, are there treatments available, and would the patient want to have treatment, and what are the side effects of the treatment, and what are the gains, what are we hoping to achieve with treatment. And I don't think it's fair to say that there's never a point at which we have treatment. It's just important to think about what treatments. So are we talking chemotherapeutic treatments? And it would be fair to say that there is a limited armamentarium, as we've described, in terms of what treatments are available. Often patients can be considered for radiotherapy at any stage, and that's really important to think about. Radiotherapy can be really effective for pain control. Symptom control is really important, but I think the bottom line is the decision for treatment is very much with the patient, but it's important for the doctor to be open and honest about what we're hoping to achieve with treatment, and particularly what side effects the treatments may have.
Thank you. So you outlined the various different options at each relapse, but how do you as a doctor decide who should have what, and do genetics play a part in any of your consideration?
Okay, so we have a certain schedule that we're following that may not necessarily be our choice, but it's within the armamentarium that we're able to deliver. But I do think that we are able to modify treatment for patients. So for example, patients with what are called higher risk or genetic features that mean that they're likely to relapse sooner. So classically, we would talk about abnormalities such as a 414 abnormality, or maybe P53 deletion. Some of those patients are probably likely to benefit, certainly in the initial phase of their illness, with a Velcade or a bortezomib-based regimen, so that we do tailor treatment for that. The second thing is that we would tailor the treatment according to how we feel somebody will tolerate treatment, and also whether we think that treatment is likely to cause significant side effects. And then I think finally, clearly for patients who are fit and well enough for treatment, we would consider a stem cell transplant, so that would be more intensive treatment. And certainly in some institutions, depending on their genetic risk, we might be talking about what's called a tandem transplant, which may be having 2 transplants back to back after about 3 or 4 months.
So you did touch on this already about how COVID-19 has changed the treatment options available, but could you elaborate a little bit more on that?
Okay, so I think the premise of the COVID-19 changes are that I think the government allowed more money to be available as a way of trying to limit or prevent patients coming into hospital, because it's accepted that the fact of somebody leaving their home, coming to hospital, attending a chemotherapy day unit, going home puts you at risk of COVID. We all do our best. We're tested as doctors and nurses, but people are trying to limit that. There are also some regimens that would involve, for example, weekly attendance at the hospital. So the COVID planning, as I describe it, a means of trying to limit exposure for patients to COVID. So that would mean that there are some oral treatments that would not normally be available at the specific lines that we've discussed, as a way of having an alternative treatment to mean that patients wouldn't need to come to hospital and could be treated at home. So that would mean that patients could receive, for example, ixazomib, the oral proteasome inhibitor, with lenalidomide and dexamethasone at first relapse or second line, because normally it would be at second relapse or third line. So in other words, one further up the pathway. And also patients could receive pomalidomide, again an oral immune modulatory drug, if somebody had received lenalidomide before, and that would either be at second or third line. Normally it'd be available at fourth line. I think the other thing for COVID that we have done, and this is very much based on discussions with patients, may be that you would offer the same chemotherapy regimen that you've normally given, but maybe you're giving it on a less frequent basis. So for example, daratumumab, Velcade and dexamethasone is classically given on a weekly basis. Certainly the Velcade is given weekly, and it may be that on discussion with patients, you might decide that you might give it every 2 weeks, or you might give it every 4 weeks. So in other words, you're still getting a good and effective treatment, but you're trying to change the frequency that somebody attends hospital. So those are the COVID related issues.
Thank you. I think that's clarified it for quite a few people. I think there might be some people who are anxious that if they're given something at one point in the pathway, they can't have something else later on. What would you say to that?
So that may be true for certain things, I think, if we're honest. I think in lots of ways there's a lot more flexibility now than there has been in the past. So for example, in the past, if you'd had lenalidomide previously at all, you were unable to receive lenalidomide further up the pathway, for example. Whereas now the criteria are, so long as you haven't relapsed or refractory to that drug, you could receive that drug. You could receive that drug again. Now, most people would receive lenalidomide as continuous treatment, and towards the end of that treatment, they would be refractory to that drug because that's why their myeloma has come back. But for example, there might be a group of patients who have received lenalidomide earlier in the line, then gone on to a stem cell transplant, then been off treatment for a period of time. For example, those patients could then go on to receive lenalidomide again. So there is some flexibility. And actually, in fairness with COVID planning, it's important that we're aware that we're not disadvantaging patients for concerns about coming into hospital with COVID exposure, which is a potential and significant risk, but actually we're not prejudicing the treatments that they could receive further down. And again, this is an open discussion.
It sounds like quite a delicate balance to strike there. So thank you for answering those questions, and we can now move on to the second part of our presentation. Thank you.
Okay, so this is probably a shorter discussion, and this is just talking about clinical trials, and we can in the Q&A discussion talk about what clinical trials or the theme of clinical trials, what's happening, but this is just a talk about what the concept is of a clinical trial. And I think it's really important to just think about the stages of a clinical trial. So the clinical trial involves a new drug, should we call it a drug or a new agent, that there would have been laboratory evidence that showed that there is efficacy, that it's likely to work for patients with myeloma. So that might be on particular cells that they've grown within the laboratory, that they've exposed to the drug and shown that it's of benefit. There may be preclinical animal models at that point. Then you go on to what are called clinical trials, and the clinical trials go through multiple phases, but essentially the first phase, or phase 1, would be just making sure that this drug that has been found to, or thought to be efficacious, is it a safe drug to give? That's the first question, is it safe? And that would be a phase 1 trial. A phase 2 trial would be expanding, and there would be a very small number of patients, I would think, that are in a phase 1 trial. And often what happens is a small dose of the drug is given, and then an escalating dose of drug is given, and clearly the doctors are being very vigilant as to whether there are any concerning side effects. There are a huge number of regulations. So people aren't treated as guinea pigs. There's complete informed consent, which we'll talk about. And that's just to say, is it a safe drug to give? The phase 2 part of the trial is it safe? Because safety is paramount. But phase 2 is looking for efficacy. So at that point, it would be a slightly larger number of patients, and it would be looking at whether the drug shows promise in myeloma. So for example, does the paraprotein go down? Do the light chains go down? Does the hemoglobin stabilize, etc.? And again, is there any safety issues? And that's obviously really concerning. And then the phase 3 part of the trial is comparing, is looking again to safety and efficacy, but it's often comparing it to what would be considered standard of care. So these are drugs that have been around for a while, and the question is it more effective than what would be considered the standard treatment? And again, patients who enter trials at this stage, and these are classic national, large, multi-center trials, would be given, informed consent, very important. And then what happens is that, say a drug has been shown to go through the phase 1, it's safe, phase 2, phase 3, and we've shown it's effective, and actually better, say, than the standard of care. It then goes to licensing, and that will go to, well, we're still in Europe, it goes to EMA, and then within the UK, it goes to what's called the Medicines Health Regulatory Agency, or MHRA, and then it gets a license. And at that point, essentially, it appears in the formulary. Now, that doesn't mean that it's necessarily available to patients, because it then needs to be funded. And the funding is essentially arranged through what's called a health technology appraisal, or health technology assessment, HTA. And that involves an assessment by NICE, or the National Institute for Clinical Excellence. And they work in conjunction with NHS England to see whether it is both safe, whether it is effective and cost effective. And they're thinking about the whole NHS resource. And then if it passes that hurdle, then it would be available widely for patients. Sometimes in the health technology appraisal, they say that we have insufficient data. We know that it's effective, but we're not necessarily sure that it has all of the features that we feel that it's necessary to have it widely available for people. We want more information. And those drugs often go onto the Cancer Drug Fund, and they go on the Cancer Drug Fund for around 2 years. And for example, daratumumab, both as monotherapy and in conjunction with Velcade and Dex, would be given as on the Cancer Drug Fund, or ixazomib given with lenalidomide and Dex. Ixazomib is on the Cancer Drug Fund. Now, the important thing that I should highlight is that if you're receiving a Cancer Drug Fund drug, you're not going to have that withdrawn for you. So it's not like the 2 years have come up and we're withdrawing the drug. Anybody who starts on the treatment remains on the treatment. All of these drugs and all of these trials are all in light of what we as clinicians feel is in the patient's best interest and preference. Nobody is using patients as guinea pigs at all. Informed consent and the ability to withdraw and say, I don't want to participate, is really important. And importantly, information that you can understand. It has to be written in a language, not medical jargon. It has to be written in a language that you can understand and comprehend. So in terms of entry criteria, so the entry criteria are defined because when you open a clinical trial, you need to make sure that you're answering an appropriate question, that it is safe for patients, and that you're going to be able to give an appropriate answer to the trial. So there's no point opening a trial, enrolling 10 people, and then those 10 people have spent time and effort for no reason. So it's very important, and a lot of effort goes into making sure that the trial is effective and that you're getting appropriate answers. So the entry for the trial is very much determined by the stage of the disease. So often for the newer drugs, we're talking about giving treatment in the relapse refractory setting, and then it tends to be moved further up the pathway. It's important to think about what previous treatment patients have had and capacity. So you have to define the number, and the number is important because that gives you statistical significance when you're comparing groups. So that's called the power of the trial. So that will mean that there will be a certain number of people, for example, that are able to enter a trial, and that will always be predetermined. So in terms of choices, so there are choices for patients. There are things that you may or may not be able to have a choice in, and things that it's important to say that unfortunately you may not be able to have a choice. So clearly you will have a choice as whether you want to be enrolled in a clinical trial. You will be told, you will be given information about if you wish to withdraw. That's absolutely fine. You can choose where you have your treatment. You can choose to a degree when the trial starts, when the treatment starts. That's very much dependent on capacity. So it doesn't mean that you can define exactly, but you may get some kind of information about that. And you can choose whether you have any additional tests. So often the trial may have a baseline of tests, and then there'll be a few more add-on tests, and they again will ask you whether you want to opt in to those additional things. But you can't choose whether you're eligible for a trial because the eligibility, as I've said, has been predefined. Often the trials are randomizing between different treatments. So they might say a randomization is treatment A or treatment B. If there's a randomization, you're going to know that. But you can't say, I'll only flip the coin and I'll get treatment A and not B, because that's unfortunately the purpose of the trial. And you can't choose what dose of drug that you start with. So essentially what happens with the trials is everybody has to start, if they meet criteria, at a certain dose level. You can modify the treatment if you have problems, but the actual initial dose is always predefined. So I guess the question is when to go on a clinical trial, and I would very much support clinical trials. I think they're a very important thing, both for access to new treatments for patients, as a way of trying to understand about myeloma and a way of trying to explore new treatments both for patients and also those in the future. You need to think about trials, I think, if it fits in with what you need. The question is the trial best for me, or is it best to think about other treatments, because there may well be other standard treatments? And I guess it's important to think about what additional trips and tests are required at the trial centre. So it may be for a quality of life reason you may choose not to go on a trial, because you might say, I don't want to go to the hospital every week or twice a week. Or you might say, I accept that this is a new treatment that's going to be potentially life extending for me, and therefore I will accept that impact on my quality of life.
Thank you for that overview on clinical trials. We've got a couple of follow-up questions. So this one has come in from Catherine, and she was asking about whether the clinical trials will be restarting after they've been paused due to COVID, and will there be plenty of opportunities for relapsed or refractory patients to join them?
So I think in the height of COVID, trials were stopped, mainly because a lot of the staff were redeployed. So not only were the staff that would normally deliver normal chemotherapy and other drugs, but some of the staff that were delivering trials were redeployed, so there wasn't an ability. But actually now, and particularly in our institutions, we have restarted trials. So I think trials are open and available. They may not be open in the same capacity. They may not have the capacity that they had previously, but I'm not aware of people not being able to access trials. I don't know if that answers your question.
Yes, it's good to know that trials are opening up again, and I would assume that there are opportunities for relapsed and refractory patients.
Oh yes, so for sure there are trials open, and there are definitely options for relapsed and refractory patients, yes.
That's great to hear. So I know a lot of patients are very anxious about relapse in particular. So what would you like to say to patients who are suffering from some anxiety or worry about this? And how can they look after their mental well-being?
So I think to accept that it is normal and it is undoubtedly anxiety provoking, and not to brush it under the carpet and assume that nobody else has that, because it's normal. You know, the concept that you've had myeloma, that you've done very well, your cancer's gone away or is in remission, and then it's, you know, the concept of it coming back, or will it come back? And I think it's a very normal thing to those kinds of feelings. It may be provoked by the fact that now it's my 2-month follow-up or my 3-month follow-up, and I'm going to have a blood test. Again, that's very important, very normal. I think it's important to be open and honest. That would be my view. So it would be to try and talk to the healthcare professionals. There are ways that we can help and support you. Myeloma UK is a fantastic resource. And support within your family and friends, I think, is really important. So not to hide it and not to assume that it's unnatural. It's completely natural. Why would you not be anxious? The important thing to focus on is that there are things that can be done to prevent problems. So it's always important to focus on the fact that when you were diagnosed, it was an unknown problem. That's what I say to everybody. It was an unknown problem. You had back pain. You may have gone to your GP and other individuals for weeks, months, or whatever, a long period of time between lots of doctors and things. Whereas in the relapse setting, we have mechanisms to monitor patients and intervene before people become unwell. That's really important. And often there's very good and effective treatment available, as I've said.
Yes, thank you. I would second part of what you said, that if you are feeling anxious or you're having difficulty with your mental health and well-being, I would encourage you to get in touch with your healthcare professional team and your family and friends, and Myeloma UK. You can always call us or you can send us an email to discuss anything. So that's all the time we have for questions today. As Dr. Rabin has explained, there are a number of different treatment options available for patients at relapse, and I hope you can be encouraged by this patient quote, which is taken from our book, The Small Things That Make All the Difference. This booklet, as well as many others, are available to download from our website. And in particular, I'd like to highlight our info pack dedicated to patients with relapsing and/or refractory myeloma, and our info pack for living well with myeloma. You can also find out more about the drugs and the treatments that have been mentioned today, as well as hearing from patients themselves through our online videos. So I'll just pass it back to Dr. Aben to sum up.
So thank you very much. So I think it's really important to just think about the take-home messages. So at the start, I talked about 3 take-home messages. So the first take-home message is that myeloma will return at some point, but it's difficult to predict exactly when this will happen. Secondly, that we are able to use tests, and so we talked about blood tests, we talked about some imaging, and also clinical history, which is really important to think about symptoms and complications that help us identify relapse, and that if you have biochemical relapse, it doesn't mean that you need to have treatment. It just means that you need to have observation. That's different, obviously, that if you have clinical relapse, and then clearly there are symptoms related to myeloma. And the third take-home message, and as I've said, there is clearly treatment options available for patients with relapsed and/or refractory myeloma.
So we've come to the end of our webinar today. Thank you so much, Dr. Aben, for speaking to us and answering questions. And thank you to everyone who's joined our webinar. We hope you found it helpful. But if we didn't manage to answer your question, or this has maybe thrown up some new questions, please do get in touch with us. So you can do that via our info line or via our email service, details of which are on our website. So also keep an eye on our social media and website for announcements of further digital Infoday sessions. And once again, I'd like to thank you all for joining us, and I hope you have a good rest of your evening.